may substitute high-flow ECMO. I think we have to be careful, but we may think a little bit about it. Yesterday we heard Dan Brody, no? And Dan Brody was speaking about the mechanical ventilation during extracorporeal support, and he was saying always ECMO or ECODU or ECOR. That means that both are systems which allow a complete new setting of mechanical ventilation. As I told you yesterday, the entry criteria of ECMO since the Zeppel trial, which was done in 75, 76, was the oxygenation. And there is practically no mention about the CO2. I remind you that we breathe to eliminate CO2. We can survive without any ventilation, just if we control the CO2, just having an oxygen flow equal to the oxygen consumption. So all the damages of mechanical ventilation, I think that the real advantages of the extracorporeal support is just to make the possibility to make the mechanical ventilation less dangerous. So in my opinion, the indication of ECMO or ECOR would be, okay, I treat the patient, I look the patient, I look at the mechanics. If the overall mechanical ventilation is too risky, as an example, because the mechanical power is too high, you may discuss what is risky, but if it's too risky, if we define a threshold for that, at this point we introduce the extracorporeal support. And the extracorporeal support allows to decrease the load of mechanical ventilation. This is the key point, in my opinion, which is very often forgotten. Anyway, you see that an NIH with adult ECMO trial, also the ECOR trial was done by Alan Morris and had a very few survival in this trial, and this trial where the survival was just the people who were disconnected because excessive bleeding. So it was a little bit disaster in terms of technical. Then we have a Caesar trial. Caesar trial is a little bit, the design is a little bit complicated. And the Caesar trial went to the New England, went to the Lancet, and I think just Bob Bartlett was able to rearrange everything to get a publication of this trial, which was very discussed. And then we have the Eolia trial. And the Eolia trial look at the entry criteria, as I told you yesterday, are very similar to the Zeppel criteria. And this PO2, this is what to me is strange. We use ECMO for indication of ECMO, we use the PO2 FiO2. And in the control and in the treater, they're absolutely equal. If you do not know that, even I don't remember, the ECMO is in red and the control are in blue, how can you distinguish this one? You cannot. But look at the PaCO2 and look at the PEEP. All this as related to oxygenation is identical. This is related to the ventilation. Is sharply different. And probably the people were not realizing completely what they were doing. This is what is still to me surprising. And of course, you can control the ventilation, look in the PCO2, even with the low flow. You don't need 5 liters. When you have 5 liters, you like or you dislike, you have at least 20-30% of recirculation. And you ask why I should have a very high blood flow. For what? We had to discuss in terms of the increase of PO2, why the PO2 increases in vino venous. We discussed a little bit about that. Then, once again, in Eolia, the physical variables, which are linked to the mechanical ventilation and which are linked to the harm of mechanical ventilation are the mechanics. And you see the mechanics were different. The results of the different ventilation results in different mechanics, which result likely in different harm. So, and this is the Eolia. And this is very strange, the human mind, When Zeppel did his study in 75, 76, we had 90% more or less mortality in treated and in control group. And this killed the ECMO for at least 30 years. We were only 2 or 3 groups in the world continuously doing ECMO. In the one side of the Atlantic was Bob Bartlett. In Europe, we were doing ECHOR, more than ECMO, Lewandowski, and very few groups continue to use this technique. Why this technique resuscitated? It resuscitated thanks to our friend in Australia, when they aged A1N1, and they published a paper in which they treated some patient with a very severe respiratory failure with ECMO. All the government in Europe, because with the difference of season, start to finance the ECMO center or the ECMO approach. And the people starting with ECMO, starting with extracorporeal support, realize how powerful technique it was to correct the symptoms. But in terms of the classical evidence-based medicine, even the Eolia did not succeed. Eolia was interrupted because of no impossibility to reach the goal. But the climate was changed. For the same results, more or less the same result, but the same rough results, so failure, in one case, ECMO was banned. In the other case, when the people said, this is the most positive trial of the negative trial, what does it mean? Nothing. The myth of the evidence-based medicine. The evidence-based medicine was invented in UK at the time of the Thatcher to save money on the health sanitary system. This is the scientific background of what has become a dogma. This was the origin of the evidence-based medicine. Anyway, this is a very old slide. Yesterday, we heard about the oxygenation in ECMO and the shunt in ECMO. Now, if you take the shunt formula and you look at a patient in ECMO with very high SVO2, the shunt becomes enormous, 90%. But what does it mean? The improvement of oxygenation that we had is due to the increase of the oxygen content through the shunted areas. That means through the areas in which the gas exchange contact into the lung does not exist. More I provide oxygen with here, less I provide oxygen through the normal lungs. It's a balance. If I arrive with 100% of saturation, I don't have space to have oxygen. So all the game is played in the shunted areas. And for shunted means the regions of the lung in which the contact with the alveolar gases was null. And this is what's happened in a very high flow ECMO. For the CO2 removal, due to the very high CO2 content, in theory, is enough half a liter of blood to clear all the CO2 metabolic production. So we have to play with this dissociation. You have a tremendous possibility of combination of the two, which cannot be tested in all randomized trials, because randomized trial you test 2-3 hypotheses. The variety of approach you have in the hands is far greater. And so, we try to, on a very difficult study, to use some Deutsch pigs. We have a 24, quite big, about 50 kilos pig, in which we say, not simulate, but just to have an idea, we induce respiratory failure in one group, giving the chlorine acid through direct instillation. And the chlorine acid goes, it depends, no? A little bit to the right, a little bit to the left, and so on. And in other groups, we were using the oleic acid. With the oleic acid, all the lung is exposed to the noxious stimulus which comes from the blood. So in one case, you have a sort of primary LDS. In the second case, as in peritonitis and so on, we have something coming from the blood to which all the lung is exposed. Then we had some control. Then we have the ECMO groups. The ECMO groups had a flow about 50 milliliters per kilo. In 50 kilo pigs are 2.5 liters, 3 liters, okay? In the other groups, we have half a liter. So we have a tremendous difference in the two groups. And was really, this kind of study are really complicated when inducing the noxious stimulus, no? Because it takes hours, it's a really demanding study. Now, after the injury, what's happened? The hydrochloric acid had a little bit better oxygenation, and oleic acid a little bit worse. Plateau pressure was a little bit different, but clinically not very important. The stress, that means the transpulmonary pressure, was higher in hydrochloric acid. The wedge pressure was also a little bit higher. So the models are different. And what we call, let's say, ARDS, as we do in clinical practice, we involve a patient in which the basic pathophysiology may be completely different on one side. And these are the results. This was quite a little bit surprising, because look at the oxygen consumption. I didn't expect that. But the oxygen consumption was, in both groups, was quite high in extra low flow, and we had a dramatic change, dramatic decrease in oxygen consumption in the oleic acid. Now, oxygen consumption is one of the most difficult measurements in intensive care, and usually nobody measures it, but it's the fundamental of the life. We are alive because we have a continuous flow of energy, and oxygen consumption is a measure of energy. The energy requirement in oleic acid in this model was dramatically lower. and the same with CO2. That means that the results are consistent. More oxygen you consume, more CO2 you produced. And if I have an extracorporeal CO2 removal of 50 or 100 milliliters, one thing is if my total CO2 is 200, another thing is 300. And tell me who measured that in clinical practice. I think measurements is the only way we have to understand what's going on. And then the PaO2. With extracorporeal CO2 removal, we give 10 milliliters of oxygen per minute. We give far more, of course, with ECMO, the classical ECMO, high flow. But look at the PO2. Because we were arranging a little bit the ventilation to make the ventilation more adapted to the overall situation. But the initial 3-4 hours, after 3-4 hours, we didn't find any great difference on that. The same thing was found in humans now with Chiumello. We had a small sample that surprisingly PO2 was not a major problem.
2 minutes, Prof. Gattinoni.
Yes. I'm finished. High versus low arterial oxygen saturation. This is important. The vascular resistances. Because when you have a big amount of flow, oxygen flow coming into the blood, we have a loss of the hypoxic vasoconstriction, which is maintained with extracorporeal CO2 removal. And the end of the story you see here, the respiratory system elastance was much worse with ECMO, because we were decreasing too much the ventilation. And we have the protective ventilation, the lung becomes more and more stiffer. So, and this is a conclusive slide, when you compare these two groups, we have 3 factors. One factor is due to the model, which is different. Another factor is due to the technique per se, the amount as SVO2 as an example, which is the hypoxic vasoconstriction, hemodynamics, etc. And a third factor is the operator, what we do with the lungs. So the picture is very complex, but I think there is a lot of way to go into before to discharge completely the extracorporeal CO2 approach, which is theoretically more simple. Thank you for the attention.